Hello, hello.
Yes, yes, sir.
Okay, so let's start our session. Okay, so we were discussing about our multiple myeloma, right? So in multiple myeloma, we discussed these are plasma cell dyscrasia. What do we mean by plasma cell dyscrasia? It's a neoplastic proliferation of your plasma cells. What are the function of plasma cell? We discussed it in immunology that plasma cells basically make antibodies, right? So if you have malignant proliferation of plasma cells, it means now the plasma cells are going to go mad. They're going to make a lot of antibodies, right? Okay. We discussed these neoplastic cells can activate your rank L. We know the concept. We have discussed it multiple times. As we have rank L activation, increase osteoclastic activity. What does these osteoclasts do? They'll just eat your bone. So we are going to be having lytic lesion in the skull and vertebra, right? We discussed that. And as we discussed that, although we have a lot of, it's a neoplastic proliferation of your plasma cells giving us a lot of antibodies, but since it's a cancerous condition, so it would be monoclonal. We discussed the concept of monoclonal and polyclonal. Monoclonal do not have ability to fight off against a lot of epitopes on an antigen, while a polyclonal, since they comes from a lot of diversity, they have the ability to attack or multiple antigens, right? Okay, so we were discussing that although we have a lot of antibodies, IgG, IgA, but the problem there is that we will still be having infection because those antibodies aren't, proper antibodies. They are defective antibodies being made in the rush, right? We discussed about Rolu formation. So I was just discussing that red blood cells, both of them have equal charge. Normally, the red blood cells should repel one another, right? But if the charges between the red blood cell decreases, we already know that they are going to attract then one another. They are going to come close to one another. And as these red blood cells just come close towards one another, they would just stack up on one another, right? Just a pile of coins, right? So these stacking up of the red blood cells upon one another are known as Rolu formation. Okay, is it clear? Hello, hello, hello.
Yes.
Yes,
Oh,
yes, sir.
perfect. Another thing we discussed these are plasma cells making a lot of antibodies, right? So we can get a lot of antibodies. We can get a lot of IgG heavy chains. We'll be having a lot of IgG light chains. Light chains and heavy chains are basically the component of your your antibodies. We know that. So in this neoplastic proliferation, if you're having a lot of these chains, these AL amyloidosis, the word is amyloidosis light chain. So sometimes if you have a lot of light chain, they can just build up in the blood and it would start depositing into different tissues. That's amyloidosis. We can discuss the concept of amyloidosis. We're going to discuss the exact amyloidosis topic is going to be in our general pathology. But let me just give you an hint. Amyloidosis is simply whenever the disorganized proteinaceous particles or proteinaceous structures, whenever their level grow inside your blood and they started depositing in different tissue, you call it amyloidosis. So amyloidosis can be due to a lot of things. If you guys remember in immunology, we discussed beta 2 microglobulin amyloidosis in dialysis related individual. Remember, it cannot filter the beta 2, which was the component of MHC1 leading to amyloidosis. Sometimes it can give you which syndrome? Flexor retinaculum, if it deposited there. What's going to be the problem then?
Carpet channel.
Carpal tunnel syndrome. So, right? And we discussed it's always going to be seen in dialysis related amyloidosis, right? Because in dialysis, you cannot filter out that beta 2 component of MHC1. It can build up, it can get into a lot of tissues. So, same is the concept here. If you have a lot of light chains being made, they are building in the blood. Obviously, what would they do? They would just start depositing in different tissue. And as they get deposited, they're going to be called as amyloidosis. In our renal section, we discussed okay, some apple green is something. Did you guys remember that? Who's going to be telling me that? Plain polarized light, amyloidosis. Was it a nephritic or nephrotic syndrome?
It's nephrotic.
Nephrotic.
Nephrotic. Nephrotic.
Nephrotic.
Syndrome.
Nephrotic syndrome. Perfect. And what was the characteristic features of that? Apple green. I'm just giving you a hint.
Apple green by
Uh,
fringe.
yeah, birthday.
When flame polarizes, light is fast and having which dye? What was the name of the dye?
On Congo red cell stain.
Congo red. Same.
Red stain, yeah.
Okay, perfect. Right? So we'll be having a lot of AL amyloidoses that can deposit in different tissues, and even the AL level are going to be so high, so like we are going to be so high, we are going to be having so high level of these antibodies that they can appear in urine as well, right? So once these free light chains of immunoglobulins appear in urine, we are going to call them as Benz-Jones protein, right? So once they come to your urine, you are going to give them a noble name, right? Because they're just coming in urine, right? So the novel name for them would be Benz Jones. It's a novel name, Benz Jones protein, right? They are simply those light chain, you know, light chain, nothing else. But we are just giving them respect. That is Benz Jones protein. Okay. So don't just whenever you see Benz Jones protein, these are you are saying light chain, nothing else. Okay. Okay. So let me just erase it. Okay. So you guys can see it's like that simple, right? So we in our bootcamp session, once we are just revising it from, the bootcamp session is going to be really great. Why? Because we discuss things from pathoma in a really detailed way, right? In the first aid, you have 1 to 2 lines on everything, right? Okay. Then we have MGUS. What is MGUS? Let's just break the name here. Monoclonal gammopathy of undetermined significance. So what would happen in MGUS? We're going to be having again, it's a dysphagia. We are just reading the same topic, right? You're going to be having a lot of M spike. What was your M spike? A lot of immunoglobulin form serum electrophoresis, right? Other feature of multiple myeloma are if absent. That is no monolytic lesion, no hypercalcemia, no amyloidosis, no Benz-Johnson. That's MGUS of undetermined significance. It do not have significance if it isn't causing problems like multiple myeloma, right? But still, you are going to be having a lot of M spike, right? Commonly seen in elderly, and 1% of them can just get into multiple myeloma. That's simple, right? Okay, while there's a macroglobulinemia. What does the name macro indicates? Again, it's the same topic, so it means it's a B cell lymphoma, cancer. But it's a macro. Now we won't be having that IgG or IgA in case of multiple myeloma. We'll be having a macro, a big one. What is the most big one among all of them? We discussed that in our
Yeah.
immunology. That's IgM, pentamer, right?
Right.
Okay, and the clinical features include, okay, what are the clinical features? As they are just indicating, we are going to be having generalized lymphadenopathy because it's a cancer of B cells. We know that increased M spike. And if we have a lot of IgM, it's going to lead to hyperviscosity. So if you remember, if we have hyperviscosity, what would happen? We can have neurological deficit. The concept is that hyper or viscous blood can move very slowly in your blood vessel. So it's going to appear as, having retinal hemorrhages, stroke, IgM is going to be a pentamer due to hyperviscosity. We discussed it can lead to bleeding, but because if the blood is moving really slow, we can have a lot of the platelets and the different factors cannot just perform their normal activity, right? So it can just lead to bleeding, viscous serum defective in platelets aggregation. So simply you can think of if the environment is really viscous for anything. So it's really hard for them to flow. Like for example, you can just compare water with honey. Honey is more viscous, right? If things are moving in the honey, it would just take a lot of time for them. So simply you can just imagine of platelets that in the viscous, hyper viscous blood, their aggregation or coming towards one another is going to be really slow. That's why we're going to be having bleeding, right? Okay. So then we have acute complication are treated by plasmapheresis. We know that. Okay. And you can just remove the IgM from the plasma from the blood. That's going to be really simple. Okay. So our last topic is going to be Langerhans cells histiocytosis. What are our Langerhans cells? Do you guys remember something of dendritic cells we discussed?
Yeah, modified macrophages and tissues.
Modified and skin, yes, perfect. In skin, we have modified macrophages. We call them dendritic cell, Langerhans, and simply, if we get cancer of those, we don't simply call them Langerhans histiocytosis, right? So Okay, they are derived from bone marrow. We know that since monocyte macrophages comes from the myelin lineage of the bone marrow. Some of you guys know that they are coming from bone marrow. Present antigen to T cell. We know that macrophages can be antigen presenting cells. They can take the bug presented on MSC2, but only the proteinaceous part, if you guys remember, right? If we have neoplastic proliferation of those Langerhans, they're really interesting on the they are going to appear as a tennis racket. And you can see, if you see these tennis racket on your picture, okay, let me show you. Okay. Mhm. What is it rolling? Again, I have to find the page. Please just tell me what's the page number. Well,
64.
64.
Yes.
Mhm. I have to find the page number 64. Okay. Okay. Okay, Langerhans histiocytosis. We discussed that Langerhans cells or these dendritic cells can be your antigen presenting cells because they're modified macrophages. They can present something on MHC2 going to CD4. We know the entire story. Either Th1 response, whether with interleukin 2, Th2 response with interleukin 4. We discussed it multiple times. So now you guys are going to make sense of that, right? Okay, so they are going to appear as a tennis racket. You guys can see it is a tennis racket, right? But a little bit old version of tennis racket. You can see it. So also known as Bayer granules on electron microscopy, Bayer granules which are resembling a tennis racket. What are going to be present on their surface? CD1A and S100 positive. S100 positive is basically present on a lot of things, on melanoma, everything, right? Okay, so we have three different types of them which you have to memorize. They aren't that high yield, right? They aren't high yield, but let's just see it for these three things. Let me just give you a mnemonic. Everything is going to be really easy then, okay? Where is my pencil? This is mine. Remember, whatever name starts with some scientist name, that's going to be malignant. Okay? Whatever start with someone names, letter, sieve disease, hand, skull for placement disease. It's the name of someone, right? So they're going to be malignant, right? These names are so malignant, you guys can see. It's really hard for them to memorize, right? Okay. Okay, it's really hard to get them into your brain, right? These names. So they are going to be malignant and they're going to be present in children. That's really important. Malignant. Whenever it starts with someone name, present in children. What else? They are going to invade your skin and skeletal defects. And whenever it starts with someone named, they are going to be malignant, present in children, defect of skin, and skeletal muscles. Skeletal, your skeletal system. Okay. So let's read whether we are correct or not. Letter C, disease, right? Malignant proliferation of Langerhans cells, classically in children less than 2 years, skin rash and skeletal defect, multiple organ may be involved, rapidly fatal. Malignant because start with someone name. You want to be to the scalp rash, scalp is your skin, skull defect, again, skeletal defect, diabetes insipidus and exophthalmos in child, again. That was so simple, right? Okay. Since this name do not start with someone name, so it's going to be benign, right? It do not start with someone name, so no skin involvement is going to be seen. But we have pathological fracture in adolescent. That's the only thing which you have to do. Okay. So the biopsy would show Langerhans cells with, okay, all of them are Langerhans cells, right? So it's common for everything. Include numerous eosinophils. As the name indicates, it's eosinophilic granuloma as well. So it's so simple. Okay. If it starts with someone name, it's going to be present in children, it's going to be malignant, it's going to be involving your skin, your skeleton. That's all. So letter C disease, and what is common? It's the cancer of Langerhans cells. Langerhans cells, malignant. Skeletal defect, skin rash, we know that. Okay. Less than 2 years in children, exophthalmos, diabetes insipidus, just add these two extra. So that was all about our white blood cells, our red blood cells, our platelets. Now we'll be starting our bootcamp session. We have remaining pharmacology. Once we are done with the bootcamp session, tomorrow you guys are going to be having assessment. Along with that, I'm also going to arrange a class for pharmacology. Pharmacology is really easy. So that was all about the system. I do understand it was a little bit, big system because we covered it from two different resources, but also you guys enjoy it. It will be really easy for you guys to grab the concept if you do it from the form. These are already right first. So, can I have 5 minutes of break and then we can start our bootcamp session? So let me just tell you, we have decided that bootcamp session is going to be started from first year, red blood cell module. Then we are going to be doing this white blood cell. And you guys are going to be answering me a lot of things because you guys did pathoma, you guys know the concepts, the association and the arrangement in first year is really disorganized. So everyone should be prepared that I can ask them what different things. Okay? So that's going to be a kind of, we're using this as a checklist. We know this, we know this, we know this. Okay. So let's have 5 minutes of break and then we'll be starting our recon session, starting with first aid reading. Thank you so much. Hello. Hello.
Yes.
Oh, so let's start our bootcamp session. Okay, so I'll be just going over all of these things, anemias. We discuss different types. We discuss microcytic, normocytic, macrocytic, and everything. We know everything, right? We discussed something called reticulocyte count or corrected reticulocyte count. Did you guys remember what was corrected reticulocyte count? Yes, please. Okay, let me just use someone. So you guys are going to be really responsive in this second. Okay, let me just open this. So everyone is going to get a chance. Dr. AB. Dr. AB, can you just please turn on your mic? Can you just please tell us something about reticulocyte count? Dr. AB. Okay, Dr. Adonia. Adonia, Dr. Adonia, can you please turn on your mic? Hello. Dr. Aksal
Hi.
Iqbal. Hello.
Yes, yes.
Okay, we discussed something about corrected reticulocyte count. Can you just please summarize that?
I missed that discussion and I didn't get that lecture either. So
Okay.
yeah.
Okay. Let me just give you an overview of that. Okay. We
Okay.
were discussing normocytic anemia, right? We were discussing normocytic anemia. We discussed that normocytic anemia. Okay, what is normocytic anemia? The MCV is going to be normal line in normal range 80 to 100, right? We discussed that normocytic anemia can be due to two reasons. The first reason can be due to underproduction by your bone marrow. The second reason is going to be due to peripheral destruction of your red blood cell. Do you guys remember it? Hello? We discussed how to differentiate whether normocytic anemia is due to underproduction of your bone marrow or whether it's going to be due to, peripheral destruction of your red blood cell. We know we are going to look for something called corrected reticulocyte count, not reticulocyte count, right? Okay. So if we have normocytic anemia and corrected reticulocyte count is greater than 3%, it indicates the normal functioning bone marrow because we are destroying them peripherally, and your bone marrow is basically giving an attempt in order to restore their values or their concentration. So that's why what would happen? The corrected reticulocyte count is going to be greater than 3%. Did you guys remember that? Hello? Okay. And if we have normocytic anemia and corrected reticulocyte count is less than 3%, we know that that was basically, problems with the bone marrow, cannot make enough red blood cells. So it's normocytic anemia due to failure of function of your bone marrow hematopoietic stem cell. Is that clear?
Yes.
Perfect. We discussed something called corrected reticulocyte count, not reticulocyte count, because what was the reticulocyte we discussed is basically an immature red blood cell. We discussed we can sometimes have false elevation of that reticulocyte count. Like we discussed, if you have five people, let's suppose if you're just taking one ratio. So as we are decreasing the entire community of these people, so the percentage of those constant people can rise, right? So it's going to be a false elevation. Although we have constant, population of reticulocyte count, but due to peripheral destruction, we can have false elevated value. That's why we were discussing about corrected reticulocyte count. So in that case, we have to take the reticulocyte count, multiply it with the hematocrit of an individual, divided by the normal hematocrit, which is 45. That's a corrected reticulocyte count. Is it clear?
Yes.
Okay. Then
Can
we
you
discuss.
can you put values in this equation so that it's easier to understand?
Okay. The value in the equation, it depend upon every individual can have different values, right? So if they're given you corrected reticulocyte count, they're given you the hemoglobin of that individual. So you are going to then use this formula, right? Because it's going to be different RPI for different individuals. So which values do you want me to put in? Just give me some values and I'll just put in and solve the equation.
Uh, the average, I guess, I don't know what the average maturation time is.
Okay, this maturation time, it's a constant value, right? It's a constant value. So if you can just skip a constant value, only use this equation, that's enough, right?
Okay.
In any equation, the constant values are constant for everything, right? So they do not have enough significance. That's only to make, a value smaller or greater. If you are dividing it, it means you are making a value smaller. That's only, like a basic rule of mathematics, right?
Yes.
Okay, so interpretation of our serum iron studies. We discussed each and everything. Let's just go through, iron deficiency. If you have iron deficiency, first of all, what would happen to ferritin stores? Ferritin store, the storage one, in the macrophages of your liver and you remember, bone marrow storage ferritin. That would go down. Remember? Hello?
Yes.
Yes.
Ferritin and transferrin have inverse relation we discussed. So transferrin would go up. Transferrin are basically, this TIBC is basically the number of transferrin molecules, right? So if transferrins are going up, TIBC go up. As we have less iron in the serum iron will go down. And What will happen to the percentage saturation? What I just told you about a normal individual. Normal individual have 33% of percentage saturation in pathoma. You guys remember, right? So you to an individual with iron deficiency is going to be less than 33%, right? Is it clear? Because we have less iron. Is this clear?
Yes.
Okay, perfect. Anemia of chronic disease, hepcidin release. What would hepcidin do? Hepcidin is going to do two things. First of all, it's going to go into your ferritin stores. It won't allow iron to come out. Then it would go into your duodenum. It won't tell it will stop the receptors to reabsorb more iron. So in the end, you will be having less serum iron, but still the ferritin stores are a lot of stores, right? So ferritin increases. Inverse relation with TIBC, what would happen to TIBC? TIBC decreases. Is it clear? Hello?
Yes.
Hello. What happened to serum iron? It decreases because the iron can neither be reabsorbed by the gut and neither it can be coming from the stores into the blood. So from two sides, the iron come into your blood, either from the storage or either from reabsorption. Hepcidin causes both of those, transporter of iron. What will happen to the percentage saturation? It would decrease or either it can remain constant. Hemochromatosis, iron overload. We discussed two concepts. Either it can be primary, it can be secondary. Primary due to overactivity of paraprotein. Secondary in beta thalassemia, we are giving a lot of transfusion. It can lead to secondary or hemochromatosis. Ferritin stores are going to be increased. Transferrin decreases.
Mm.
Right? We have a lot of iron. Increased serum iron, increased percentage saturation. It's an iron overload state. In pregnancy, you are doing only one thing or oral contraceptive pills. Estrogen component is going to do one thing, sir, only. It's going to increase the transferrin from your liver. So as the transferrin are all going to be increased. So TIBC increases. We have normal serum iron. We have normal ferritin, right? But as we have a lot of transferrin, as a result of that, the percentage saturation of transferrin is going to be decreased. That's the only thing you are going to see in pregnancy or OCPs. Due to that estrogen component is going to stimulate your liver to make a lot of transferrin from the liver. Is that clear?
Mm.
Okay. Okay. So let's just move to our next page. That's microcytic hypochromic anemia. When do we get microcytic anemia? If you guys remember the entire story, whenever we have less component within the red blood cell, we are going to be having an extra division. Component of red blood cell are hemoglobin. It means if we have less hemoglobin, we are going to be having extra division, microcytosis, right? Hemoglobin is made up of heme, it's made up of iron, heme is made up of iron, protoporphyrin plus beta chains or alpha chains. So whenever we have problem with anything, it's going to first lead to normocytosis, anemia, and then it's going to lead to microcytosis, if you guys remember. So the first one was iron deficiency anemia as a microcytosis, if you guys remember the concept from pathoma, right? So if you have iron deficiency, how do we get iron deficiency? If you're losing a lot of blood have iron, we are losing iron. So in case of severe GI bleeding, severe menorrhagia, severe menstrual bleed, we're going to be losing blood along with iron component as well. It is going to lead to iron deficiency anemia in the end. Malabsorption, if you can, okay, I just told you that your gastric HCl basically let the iron to stay in Fe plus 2, which can then bind to your protoporphyrin, giving you heme. So if you do not have your, your stomach, if someone is having gastrectomy, it would stay in Fe plus 3 state. Can Fe plus 3 contribute in formation of heme? Yes or no? Can Fe plus 3 bind to protoporphyrin?
No.
No, if we have gastrectomy, more of the iron is going to stay in Fe plus 3 state, and Fe plus 3 cannot be binded to your protoporphyrin, iron deficiency anemia again. In gastrectomy, increased demand. We are making baby. Baby itself require a lot of red blood cells, and if you have sufficient amount of let's suppose iron only for the mother, and if further she get pregnant without taking any iron supplement, so we have increased the demand of iron, and then in the end, she can develop iron deficiency anemia. That makes sense. And decrease the final step in heme synthesis. What was the final step in heme synthesis? Ferrochelatase. Remember, putting iron into your protoporphyrin, giving you heme. So whenever you have disruption with ferrochelatase, which we'll be discussing in lead poisoning, we won't be having that iron being attached to hydroblastic anemia and everything, right? Remember. Okay, so what would be the labs? We know the labs. What will happen to the ferritin? Ferritin would go down. And as the ferritin go down, we have inverse relation between ferritin and transferrin. Transferrin would go up. Decrease serum iron, increase free erythrocyte protoporphyrin. So if we have less iron, protoporphyrin are still sufficient. They'll be waiting for the iron, but they would never get an iron. So the level of them as compared to the iron would increase. So increase free erythrocyte protoporphyrin. Increase RDW. RDW is red blood cells distribution rate. Okay, so as we discussed, we are going to be having microcytosis, but it's a gradual process going on. So if we discuss, first of all, we will be having microcytic, and in the end, we can get microcytosis. And further microcytic, hypochromic, further small or less component. So you can see we have a lot of variation of sizes of these red blood cells. So this increased variation in size is basically known as RDW, red blood cell distribution weight. We have different width of red blood cells. So RDW increases in this case. We know that. Okay. What will happen to RI? What is RI? Reticulocyte index. It would decrease. Why? Because we cannot make, the red blood cell if you do not have iron with time. If you do not have hemoglobin. So the RI would drop down. That's really important. Microcytosis with hypochromasia. What do we mean by
Less
hypochromasia?
color.
What is chromasia?
Less
Chromasia is colored.
Central palette. Yes. Palette.
color.
Okay.
Color.
Chromasia is colored. What gives color to your red blood cell? Hemoglobin does that, right? Hello?
Yes.
So hypochromasia means less color. Can I say there's less hemoglobin? So if you have less hemoglobin, the central pallor is going to be big because central pallor indicates no hemoglobin. That's why it's a central pallor, right? Hello.
Yes.
Okay. So with time, normocytic anemia, microcytic anemia, and further microcytic hypochromic anemia, things are decreasing with time. Hemoglobin is decreasing with time. Is it clear? Yes or no? Okay.
Yes.
I'm just discussing each and every point of this first check and explaining it. So you guys should be ready, So don't want to miss a single thing, right? Okay, so fatigue, conjunctival failure, we know restless leg syndrome, really important. An individual with iron deficiency is going to be restless because he is getting iron. He want to get iron, he is going to be really anxious for that. And even he, for in the search of iron, they can start eating some soil as well. What if the soil have iron? They can just start chewing on ice, on ice because they're in search of iron. They're really anxious about that iron to get some iron. Pica is basically a disorder in which an individual eats non-nutritious things. Clay, clay is a non-nutritious thing. Ice, that's a non-nutritious thing. So a child having increased craving for ice should be, somehow diagnosed for iron deficiency anemia if he's pale and everything else is present. Restless. Individual is going to be really restless. Why? Because he need iron, right? Okay, spoon, koilonychia, spoon shaped nails. That's really simple. You guys know it. Okay, we discussed Plummer-Wilson syndrome in detail. Three things are going to be present here: atrophy, and as we have those atrophy, the red blood cell vessels, the red vessels are going to be exposed, which is going to give you appearance of beefy red tongue, glossitis.
Mhm.
Remember? Esophageal web. What was the web? Increased outgrowth of those mucosa, giving you web, giving you that. We'll be doing it in our GI section. But what is esophageal web? It's a small outgrowth of your mucosa. So if mucosa is protruded, we'll be having dysphagia with that. We know that. So three things in Plummer-Wilson syndrome: triad of iron deficiency anemia. That's the first thing. Esophageal web with dysphagia. Already, if we have esophageal web, food cannot pass through that obstruction to this outlet, or to that outgrowth. So we are going to be having dysphagia. That's really simple. Is it clear? Hello.
Yes.
Okay, perfect. Let's just discuss thalassemia. We discussed thalassemia in detail, if you guys remember. Four chromosomes for alpha chain. Remember alpha chain on chromosome 16. Remember? Hello, hello, hello. Okay. If one is deleted, it's going to be due to gene deletion. Really important. You can see that on your exam day. Remember, alpha thalassemia is due to mutation or deletion. Deletion. You
Mhm.
can see that on your exam day. Okay. Okay. Beta thalassemia either due to mutation or deletion. That's mutation. Keep that in mind. Okay. So we discussed we can have four chromosomes, or four different genes for alpha, right? Okay. So if one is deleted, no problem. That's going to be a minor case. If two of them are deleted, it's going to be a minor problem for those who are having this condition. But we have two variants, cis and trans. We can either have deletion at the same chromosome We can either have deletion on same chromosome, or either we can have deletion on one and one on the other chromosome, right? Hello? Okay, so this is a cis variant, this is a trans variant. Both of them are going to be a minimum problem for an individual carrying these. But the cis is going to be more problematic for offspring. We discussed that that's going to be one of your UWorld MCQ. Because if you get the cis into the baby, right, what would happen? By any chance, if you get a single one deleted from other parent, you can have a major, but because when three are deleted, it's going to be a major problem, right? In that case, the beta is going to make a tetramer, which is going to make hemoglobin H that can destroy the red blood cell, a lot of anemia, microcytic hypochronic anemia. If four of them are deleted, no alpha chain. So the gamma in the baby are going to aggregate. They're going to make hemoglobin BART, hydrops fetalis. We did each and everything. If you guys remember, it's
Yes.
an overview, right? So things are simple, same as that of pathoma, but in the pathoma we did it in a big detail, right? So you can see, but they're organized. In pathoma, you guys can see they have organized it. Like here, they have just jumped directly into alpha thalassemia. You know, pathoma have just properly said about the iron first and the iron deficiency. The next one was anemia of chronic disease associated with the iron. Then they just moved towards the globin. That was a very best kind of orientation of these topics, right? Okay,
Mm.
beta thalassemia, it's root mutation at 11. Only two genes are responsible. You know, so if we have, either one is okay. So we discussed we can have two variants, beta plus or beta naught. Beta naught was basically for no beta chain being made. Beta plus was basically for what? Beta plus was for. Okay, just give me a second. I'm just looking for. Okay, don't know. Doctor, let me just okay. Suddenly you just came in my mind, Doctor. Then you know, I was just searching for you. Okay, so you're here. Good. Okay, so we have beta plus and beta naught, right?
Mm.
So in beta naught variant, you know, they won't be having any ability to make beta chains, zero beta chain. Beta plus, they are going to make less amount of beta. Okay. So either we can have beta plus, okay, a normal beta or beta plus. There's going to be a minor one, right? No problem. But if we have beta plus or beta naught or beta naught, there's going to be an intermediate set. You can see. In the first one, we have one normal, the other is defective. Okay, so this is going to be your beta or beta plus. Okay, still you have one normal and the other is making less. So still you have sufficient beta, no problem. It's a minor condition. Mild microcytic anemia, we know that. But if beta
Mm.
plus and beta
Excuse,
plus, further we are working.
excuse me, Dr. Ahmed. You said that in the number one, like both are beta. One is pink and other is gray. What is this meaning? These are B plus and B zero.
Yes,
B.
they haven't mentioned in this first chat, but the one is beta with normal B, and the other
Yeah.
is beta plus with less B. Okay, they
Yes.
haven't mentioned. This is the condition, the minor one, right? The other one is beta plus
Okay.
and beta plus. So if you just
Okay.
compare it with this, both of them are defective making less. So it means it will be making less than beta, this first variant, right? Less beta change. So it's going to be an intermediate step. And the next one is going to be beta naught or beta naught. No beta. So it's going to be a major condition, right? So they're just making different possibilities, right? One possibility can be having normal beta with beta plus, the other can be having two beta pluses or one, beta naught or other beta plus and intermediate. The other can be no beta, no beta, right? So it makes sense. If no beta, no beta, that's going to be a major case. It lies intermediate in between, so it's going to be intermediate, right? It's going to be a minor having mild or minor problems. So if we have the Cooley's anemia, also known as Cooley's anemia, when both of them are absent, severe microcytic anemia, why no beta, no hemoglobin, extra division, microcytosis, right? Increase anisopoikilocytosis. What is anisopoikilocytosis? Different shape and different sizes of red blood cells are going to be seen in this case. Different shape and different size, anisopoikilocytosis. Okay. We require blood transfusion for them. We know it can lead to secondary hemochromatosis. We discussed that in this case, in beta thalassemia, like beta thalassemia and the sickle cell disease, they resemble a lot. Remember, right? Remember, they resemble a lot in the clinical features and not in the clinical features, but in other things, right? Because we are going to have extramedullary hematopoiesis in both of those cases. Both of them are problem of the beta. In both of them, we are seeing target cells. Remember these two things? So extramedullary hematopoiesis in the skull, making a lot of red blood cell undergoing a lot of hematopoiesis is going to give crew cut appearance. If you guys remember, bony outgrowth on the skull, chipmunk faces because the primitive organ which used to make your red blood cells are going to be activated now because we have increased demand. At that time, if you get parvovirus B19, it can be really fatal because we are dependent to have a lot of hematopoiesis, and parvovirus B19 temporarily shut hematopoietic stem cells. So at that time, if you have parvovirus, it's going to be a really problematic situation for individual. Hepatosplenomegaly, because spleen and liver are also going to give an attempt in order to make, four things are going to be involved: skull, facial bone, spleen, and liver. So HSM, hepatosplenomegaly. Increased parvovirus at that case is going to cause a lot of problems. We discussed that they are going to be protective against malaria falciparum as well. That isn't mentioned here, but in pathoma, if you guys remember, both of them, both sickle cell disease and beta thalassemia, I remember, protective against malaria falciparum. Okay. So first months, no problem, because in first 6 months, we're going to be having that, fetal hemoglobin with gamma. We do not have beta. And once babies start on making beta, so as these beta are defective, then you're going to see problems. That's so simple, right? So we are going to be having hemolysis and pigmented gallstones. We discussed that concept. Okay. So the other possibility which they have mentioned, sometimes you can have beta, and the other beta should can have glutamic acid replaced by valine hemoglobin S. So that's going to be a sickle cell beta thalassemia, right? So mild sickle cell problem can be seen in that, as well as mild decreased beta globin synthesis can be seen in that. That's so simple. Okay. So before discussing this topic, okay, the lead poisoning. Let me just okay, just give me a second, please. Okay, I wanted it to do from some other slides which I have got from dirty medicine in my phone. So I'll be disconnecting from here and I'll be just start continuing my session from my phone, because once we do that, things are going to get really easy for us then. Okay. Okay. Hello. Are you guys able to see my screen? Hello. Hi.
Yes.
No, no. No,
No.
no, sir.
Yes.
No, sir.
No screen.
Yes, we
Yes,
can
yes,
see.
we
I
can
can
see.
see my screen.
Yes.
Okay. Perfect. Okay. So remember, we discussed heme synthesis, how the heme is going to be made. I've just took these slides from dirty medicines, right? Okay. So in order to avoid copyright infringement, let me just give you a disclaimer. Okay. So the- okay. So the first thing which we are going to discuss is heme synthesis, right? So how do we have heme synthesis? Hello. Okay. Heme synthesis. We just discussed that in pathoma, right? But that wasn't in a big, proper detail in every enzyme. Here we are going to discuss the detail, and then we are going to move towards our, first aid. Glycine, sexin coenzyme A, in the presence of ALA synthase and B6 is going to give you aminolevulinic acid. You guys know that? The glycine was absent there. We didn't mention. So add the glycine. We discussed ALAS. We discussed B6. We discussed aminolevulinic acid as well, right? Then what would happen? Okay, really sorry. Let me just mention one thing. I'm just out at my friend place. So if you guys are, having some listening some voices or disturbance, really sorry for it. Okay, as I just told you, I was just traveling. Okay, okay.
Okay.
Hello, hello.
Yes.
Okay. Okay. I'm really sorry for the disturbance. Okay. So we were discussing this. We discussed glycine and succinyl coenzyme A combining in the presence of two things. B6 ALA is going to give you aminolevulinic acid. Okay. This process is going to occur in your mitochondria. Then aminolevulinic acid is going to move out. Okay, and it's going to move into cytosol. There, another enzyme ALAD, amino levulinic acid dehydratase, is going to convert them into porphobilinogen. Then you have another enzyme, porphobilinogen deaminase, which is going to convert it into hydroxymethylbelen. Hydroxymethylbelen is going to be converted into europyrifenogen 3. Then we have another enzyme, europyrifenogen 3 decarboxylase, which is going to convert into copropyrifenogen. Copro is going to enter into the side, the mitochondria again. It's going to be converted into protoporphyrin, and then ferrochelatase is going to attach iron into it. That's your heme synthesis. Okay, you have to memorize it. Okay, so okay. So two things which you have to keep in mind here, that aminolevulinic acid move out and copropyrifenogen move in, right? Okay, so the mnemonic which they have mentioned gets some additional point having understood the correct pathway of for heme, right? That is glycine, succinyl coenzyme, aminolevulinic propro. Okay, okay, just memorize it. Okay, so let's discuss the main thing. Whenever we have defect in any of this enzyme, we are going to be having a specific problem here,
Muhammad,
right?
can I see that slide
Yes.
again 1 minute, please?
Sorry.
Can I see the other slide? Yeah, thank you.
Okay.
Yeah, that's
Glycine. Okay, just close your eyes. Close your eyes with me. I've also closed my eyes. Okay, and I'm just doing it. Okay, so if I just get wrong, really sorry for that. Succinyl coenzyme with what? What was that? Glycine. Okay. Glycine is going to, in the presence of ALAS, and B6 is going to give me aminolevulinic acid. It's going to move out. Aminolevulinic acid acted by ALA dehydratase, converted into porphobilinogen. Porphobilinogen deaminase is going to act on it. It's going to convert porphobilinogen into hydroxymethylbelen. Hydroxymethylbelen converted into europyrifenogen. Europyrifenogen decarboxylate acted on it, converted into copropyrifenogen. Copropyrifenogen moving into the cytosol, giving us protoporphyrin. Ferrochelatase Fe plus combined. I'm really good at biochemistry. Wow. Okay, I remember things. Okay, so whenever we have defect of any enzyme here, we can have a lot of problem. If you guys remembered, we discussed sideroblastic anemia. What was your sideroblastic anemia? We discussed if any problem with heme synthesis, iron is going to stay there. Iron is going to stay there in the mitochondria. The mitochondria with iron is going to arrange itself around the nucleus, giving you a ring sideroblast. Any problem with protoporphyrin? No heme, microcytosis. Okay. So we discuss if ALA synthesis is absent, can we make porphyrins, protoporphyrins? Yes or no? No.
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 If
no,
ALA dehydratase is absent, can I make protoporphyrin?
No.
no,
If porphobilinogen deaminase is absent, can I make protoporphyrin?
no,
If europyrifenogen decarboxylate, can I make? No, I cannot make. If I cannot make protoporphyrin, iron is going to stay there, in search of protoporphyrin, but no protoporphyrin. It's going to make a lot of iron is going to enter there, making iron sideroblastic anemia whenever problem with any kind of enzyme here. So you can see ALS synthase by birth. If someone do not have ALS synthase, what would happen? It's going to lead to this was your ring sideroblast. You guys can see it. Okay. B6 deficiency isoniazid use remembered. If you do not have B6 here, can I make protoporphyrin? No. Right. So an isoniazid, you know, we can have B6 deficiency. Lead poisoning. What does lead do? Lead inhibit two enzymes, ALAD and ferrochelatase. So if I'm inhibiting ALAD and ferrochelatase, I would be having sideroblastic anemia again. Am I right? Because I cannot make protoporphyrins, right? Hello.
Yes.
Okay. So ferritin increase, TIBC low, iron increase. We know that K2 is pyridoxine. Okay. Okay. The other thing we discussed, lead is going to inhibit ALAD and ferrochelatase. Lead, ALAD, right? Lead, ALAD, right? Lead, ferrochelatase as well. Okay. So in lead poisoning, we discuss, okay, who are going to be exposed in the history you are having, like before 1978, the wall paints included lead. So whenever a child eat that wall paint, that has developed this lead poisoning. Those who are at battery ammunition or water industries using lead pipes there can get lead toxicity. That's so simple. Lead also inhibits the ribosomal RNA inside the body, inhibit the degradation of ribosomal RNA. Really important. Lead, along with inhibition of ALAD, inhibition of ferrochelatase, inhibits the degradation of your ribosomal RNA. So with time, ribosomal RNA are also going to be built in the red blood cells, which are going to appear as basophilic stippling because they are going to be blue on imaging. Basophilic stippling, you guys can see these are the remnant of ribosomal RNA, which lead have inhibited their degradation, giving us basophilic stippling. Is it clear? Lead lines. We are going to have
Sir,
lead. Yes,
sir,
please.
can you please repeat this last
Okay.
slide?
Lead inhibits the degradation of ribosomal RNA. Ribosomes have ribosomal RNA, if you guys remember, right? If lead is inhibiting ribosomal RNA degradation, okay, what do you mean by degradation inhibition? You aren't degrading. So with time they are going to build. And as they build, they're going to be appearing blue. So blue and a small like granules inside the red blood cell. So we named it as basophilic stippling. Simple.
Yes.
Okay. Okay. That's clearly mentioned in the first slide why we are going to do that. We are going to be having lead lines. What are lead lines? In the metaphysis, we are going to be having this white line, which is known as lead line. That's simple. Okay. We are going to be having these brutal lines. In the Genjua, we can have, okay, what happened? Okay. In the Genjua, you can just see we can have these lines, brutal lines with lead poison. Okay. Is it clear?
Yes.
Acute intermittent porphyria. Whenever this enzyme is deficient, porphobilinogen deaminase. So porphobilinogen is going to build up, right? Am I right? Hello.
Yes.
Yes.
If I have
Yes.
deficiency of porphobilinogen deaminase, so porphobilinogen is going to build up, right? And as it build up, it's really toxic for our body. It can damage your brain. It can damage your GI. It can damage your kidney, something, right? Polyneuropathy. It can cause a lot of problems, right? Okay, we are going to discuss that. And at the same time, okay, let me just give you a scenario. If an individual do not have porphobilinogen, and at the same time I am increasing ALA synthase activity, it means I am further building a lot of porphobilinogen. Am I right?
Yes.
Yes.
And the individual do not have porphobilinogen, but at the first place I'm increasing ALA synthase activity. It means a lot of porphobilinogen is going to be increased, and it's going to cause a lot of problems. This condition with missing this enzyme porphobilinogen deaminase is acute intermittent porphyria. So, porphobilinogen deaminase dysfunction, 5 P's, pain. It can cause, I just told you. Porphobilinogen is going to be toxic, right? Polyneuropathy, it's going to damage a lot of nerves. Psychological, it is going to damage a lot of, your brain as well. P450. At the same time, if I'm giving P450 inducers, remember, P450 inducers also increases ALA synthase activity. So if I'm just giving P450 inducers, I'm worsening this condition. Am I right? As I just gave you an example. Individual with deficiency of porphobilinogen, further increasing the activity of ALA synthesis is going to worsen the problem, right? P450 inducers increases the activity of ALA synthesis. Is this clear? Yes or no?
Yes.
Like phenytoin, bars, sulfonamides induce plus ALA synthesis. Okay. So, okay. Porphyria cutanea tarda, deficiency of this enzyme, uroparphenologin decarboxylase. Uroparphenologin is going to be, build up more. But remember, the target site for uroparphenologin is mostly going to be your skin. It's going to cause problem in the skin because in the name it's already mentioned. What's the name of this pathology? That actually it's basically porphyria cutanea tarda. Okay, cutaneous skin, problems of skin. Okay, so uropathinogen, decarboxylate dysfunction, blistering, hyperpigmentation, photosensitivity, and worsen with ethyl alcohol or hepatitis C if you're using. What's going to be the treatment? Phlebotomy. That was all. Okay. So just give me a second. Let me just open my first. Hello. Okay, guys. Really sorry. Really sorry. As I already told you, I'm just out somewhere, right? So can we just continue our session tomorrow? Tomorrow we can just extend our timing because now my friends are just telling me to have some, um, food, some dinner. So really sorry for that. Okay. So let's just continue our session tomorrow, and tomorrow I'll just finish it off.
You
Okay.
have 1 minute to answer a question, or you must leave now. I have one
Yes.
question.
Yes. Yes. Please. Yes.
Okay, so the one with the 5 P's, I didn't get it. Can you take it again one last time, please?
Yes. Definitely. Definitely. Okay.
Okay.
Okay. We discuss whenever we have deficiency of which enzyme. What was the name of what was the name of porphobilinogen deaminase, right?
Phosphobilinogen.
If we have defect or absent porphobilinogen deaminase, what would happen? Porphobilinogen would, the level would increase. Am I right? Hello?
Yes.
Yes, yes, yes.
Increased level of porphobilinogen can cause 5 P's. Increased level can enter into your stomach. It can cause pain, abdominal pain. It
Mm-hmm,
can enter into your brain. It can cause psychological disturbances, right? It
mm-hmm,
can cause port wine color urine. Okay, that was missing, right? Port wine color urine. Okay, port wine
mm-hmm.
color urine is going to cause problems in the kidneys as well. It's going to cause polyneuropathy. It's going to damage a lot of nerves, right? And as we give P450 inducers, here we have deficiency of porphobilinogen deaminase, and there we are increasing activity of ALS synthase by giving P450 inducer. It means we are further increasing the level of porphobilinogen. So five
Imagine.
P's are going to be worse and more, right?
Yes, I
And this
see.
entire pathology is acute intermittent porphyria. Is that clear?
Yes, that is
Okay,
very good.
sure. Thank you so much, and thank you for your understanding. So let me have my dinner, and tomorrow we are going to be, continuing our on the same time. Okay. Thank you
Okay.
so much. Thank you, and have a nice.